So it's important to remember that the septum is a three-dimensional structure. It's not flat. And it actually runs from the anterior left side of the patient to the posterior right side. And it has a curve to it. It's also made up of two components, the septum secundum and septum primum. The septum secundum can run a very different level of thickness. It could be lipomatous. The tunnel could be long. It could be aneurysmal. So the device is under considerable strain in different ways, in different angulations and in different vectors. So the device itself isn't very rigid. That strain, with every heartbeat, will cause some stress on the nitinol wire. So the idea that it can fracture isn't really surprising. So I don't really consider it very strongly in the assessment with the patient. Now, having said that, there has been in literature two cases that were published where wire fracture did cause a perforation and did require open surgical retrieval and repair. Having said that, that's extraordinarily rare. And I would say that it is a stress relief that the fracture occurred rather than the wire being rigid enough that it can pose a risk of erosion, which is more common in the past. Well, if the patient is stable and without symptoms, and the follow-up echo is negative and there's no pericardial effusion, then we don't manage it. There's really, it's clinically silent, and as far as the clinical decision-making is concerned, there's nothing to do. We continue as always. So it mitigates it in two ways. The delivery of the device is important, and the design of the device and its flexibility is important. A patent foramen ovale has a considerable amount of heterogeneity among patients. There's a lot of variability in terms of length, in terms of the size of the atrium, the mobility of the septum and such. So because of that, having a device that can adapt to the septum is very much an advantage. So having a flexible device that can adapt to the patient's septum and etherealize fairly quickly, whether or not it fractures is not clinically, for the most part, relevant. That plays a significant role on choice selection. I think the one comment I would make is that wireframe fracture is a consequence of a balance between creating a device that's strong and rigid and will not fracture, but has its own problems, and a device that's flexible, will adapt to the person, will adapt to the body and the variability you'll have among different patients, but also runs the risk of fracture. So it's a fine balance of getting just right where the device is flexible enough, but has that risk, but rigid enough that it is not going to happen in every single patient. And that's, it's not a zero-sum game. You do have to go somewhere between the two priorities.